I have the honor of introducing Dr. Doug Pao today, a man who really needs no introduction in this audience, so I'll give it my best shot. So, Dr. Pao attended undergrad university at Macalester College, where he was summa cum laude, and then migrated to Michigan, attended the University of Michigan, and obtained his MD, which he keeps all sports affiliations to Michigan, as anyone who knows him well would know. He then migrated out to the University of Washington in 1985 to start his residency, and ultimately did a chief residency year at Harborview, and he hasn't been able to leave. We've held on to him, and he currently holds multiple titles at the university, including professor in the Department of Medicine, director of medical student programs, endowed chair for patient-centered clinical education. Dr. Pao, amongst other things, has many numerous publications on a variety of clinical topics, as would be expected, including papers about many drug interactions, as we'll hear about today. He has over 70 peer-reviewed journal articles, over 50 book chapters. He's an invited speaker at numerous seminars, and he's a journal reviewer for multiple journals, including American Journal of Medicine, Journal of General Internal Medicine, just to name a few. He also is very involved as a teacher, which is what he probably has touched most of the lives of people in this audience with. He's the Department of Medicine coordinator for many medical student clerkships. He's nationally renowned as an educator and directed many courses at national conferences, chaired and sat on many committees for National Board of Medical Examiners. He's the course director for the ACP Board Review course. His honors and awards are really too numerous to go through, but he's received dozens of awards and honors, recognized nationally and locally. He's been elected as the ACP to Mastership and ACP Chapter Centennial Legacy Award. He's the University of Michigan Alumni Early Career Distinguished Achievement Award and our own UW-MC Turk Award. He's been involved with numerous committees and task force at the national and local level surrounding teaching and other activities. Today, he's going to speak to us about the most important drug interactions and side effects for 2015. Please join me in welcoming Doug Pao.
Thank you so much, Lindsay, for that very kind introduction. We're going to try to do this with audience response today, so some of you should have some audience response clickers, so use them generously, and that helps me see what you're thinking on these questions. Some of them have right answers, some of them don't, and just to try to keep you involved. One disclaimer, I'm going to talk about side effects and drug interactions, but the point here is not to say, don't use this drug, use this drug. It's to help us understand some of the risks that are involved when we use medications, because everything we do has to do with risk-benefit. So if we know the risk better, we know that risk-benefit ratio better. And Osler, I think, got it right. He said, one of the first duties of the physician is to educate the masses not to take medicine. And I think we do that a lot, and with the internet now, our patients are always coming in and saying, put me on this, put me on this. So there's a pressure for us to prescribe. And one of the most important things is not only efficacy of the drug, but what type of trouble can we get people into when we prescribe? So here's our first audience response case. A 65-year-old man presents with cough and fever. He's had severe diarrhea for 2 days. He was on a cruise with a friend who was diagnosed with Legionella yesterday. That's probably important information. Past medical history has diabetes, hyperlipidemia, hypertension. He's on lisinopril, simvastatin, amlodipine, gemfibrozil, metformin. His x-ray shows patchy bilateral infiltrates. He's got a high white count, a low sodium. What is the most appropriate treatment for him? So you can take a look at this guy who's sick. He's got looks like he has a pneumonia. His white count's 17,000. He's got a friend with Legionella just for fun. Got off a cruise ship, and he's on a slew of medicines. So which medicine should we give him? Amoxicillin, clavulanate, clarithromycin, levofloxacin, cefuroxime, or trimethoprim sulfa? Okay, look, the polling worked, and look at that. What a smart audience. 57% of you chose levofloxacin. And this man who may well have Legionella, that's not the core thing here. It's like, how do we avoid the drug interaction? And there are 2 drugs on this list that would be reasonable for treating Legionella. One of them is levofloxacin, the other clarithromycin. And clarithromycin we'll talk about quite a bit today about the multiple drug interactions it has and some of the most serious drug interactions that are out there. So if we look in this case, what are the drug interactions that are just kind of brewing in this case? There already is one with gemfibrozil and simvastatin in this patient, and we didn't hear that he was having any problems, so he's tolerating that well. Many people carry drug interactions around, and they're clinically fine. And we have to recognize that because it's the third or the fourth drug that we add on that often leads to the really bad things. If we chose clarithromycin, there'd be a simvastatin-clarithromycin interaction, which, in addition to the gemfibrozil, may put him at pretty high risk for rhabdomyolysis. And then we'll talk later about another interaction, amlodipine-clarithromycin, that could occur if we chose clarithromycin. So we're going to start by talking a bit about drugs that increase statin toxicity. Since so many of our patients are on statins, with the new AHA guidelines, even more patients are advised to be on statins. Fibrates have an interaction. Gemfibrozil more likely than fenofibrate. Azole antifungal is a big interaction. We don't use those all the time, so we don't see that one as much. Amiodarone can raise levels 3, 4, 5-fold for statins, so we have to be aware of that. Clarithromycin, almost never use erythromycin anymore. The key thing here is azithromycin does not have an important interaction with the statin, so if you have to pick a macrolide, azithromycin's an easier and safer one. Protease inhibitors, one that is commonly used and often overlooked are calcium channel blockers. A lot of our patients with heart disease may have AFib, and they may be needed to be put on something to slow their rate down. Calcium channel blockers are popular for that. Verapamil and diltiazem can both significantly increase statin levels. Amlodipine, nifedipine can do it as well, but a little bit to a lesser extent than verapamil, diltiazem. Sort of a key thing is if you're going to pick a statin with the least drug interactions, it's pravastatin because it's metabolized differently. Simvastatin and lovastatin probably have the most drug interactions of any of the statins. And when you don't have a choice and you have a patient where you know there's going to be an interaction, non-concurrent dosing can help. My patients all put a handful, their pills in one hand, 17 pills down the hatch first thing in the morning. I try to encourage them not to do that, but that's a common thing that patients do. So trying to separate drugs with known interactions apart will decrease how much. It won't get rid of them, but if there's no other choice, making sure they don't take the drugs together will be helpful. Why did I include this one? Well, rhabdomyolysis is the most dreaded and life-threatening statin-associated side effect. Fortunately, it's exceedingly rare just by a statin alone, but the more drugs that we line up that have this interaction, the more likely we will be to see it. We're now going to go to some more common stuff here. A 60-year-old man with coronary disease returns for follow-up. He has stopped his pravastatin because of myalgias. He previously had myalgias with atorvastatin and lovastatin. He is wary of trying another statin because of myalgias. What do you recommend for him? So we have a guy who's just achy, and we want him on a statin because he has known coronary disease, so we feel that's really important. We've tried atorvastatin. He's been on lovastatin. And now he's on pravastatin. All of these do the same thing. So what should we do? Restart the pravastatin and take naproxen, check a vitamin D level, start coenzyme Q10, or put him on ezetimibe. Lots of options here, and I don't think any one. I think that's a good response because this is not something that's a true science. This is more of an art. I think what I wouldn't do would be A. I wouldn't put him on naproxen, and we're going to talk about that later. Some of the issues with NSAIDs in people who have coronary disease. So I probably would avoid that one. I like B a lot based on some recent data and a few successes I've had in clinic with that. C is what a lot of people do, and we'll talk about the most recent meta-analysis on that, on coenzyme Q10. And then ezetimibe is certainly an option in people who are not statin tolerant, and you've done everything possible to get them on a statin, and it doesn't work. So there's not really a right answer here. I think A would be the only one I'd really steer away from. When we look at side effects of statins, we all learned, at least when the statins first came out, and many of you are so much younger than me that you don't remember when the statins first came out, but we were told, worry about the liver. You know, check transaminases every 3 months, follow those. If they go up, you do this. If they, we've really learned that's not a big issue anymore because there isn't chronic liver disease with statins. So all the hullabaloo about transaminase leak that sometimes would happen to people with statins isn't a big deal. What's a much bigger deal is myalgias. That's what gets our patients to stop the statins, and we want to keep them on. Rhabdomyolysis by itself is very rare. True liver failure, exceedingly rare. I have one patient in 25 years who's had liver failure from statin. Unfortunately, got it twice. I put him on it. Bilirubin went up to 8 in about 5 days, stopped it, got admitted with an MI. Of course, he's got to be on a statin, got put back on it, and called me up 3 or 4 days later and said, hey, I'm yellow again. What should I do? And I said, you don't happen to be on that med? Oh, yeah, I guess I am. So rare, rare, rare. It's 0.001%. But I just wanted to make the point. There are the rare people with acute liver failure from a statin as opposed to transaminase bump, which is a very different thing. And then there's some noise that maybe statins may be related to cataracts. There are a couple of studies that have been released in the last couple of years about that. And to a bad pun, we should probably keep our eye on that. So what's the deal with coenzyme Q10? You can buy it at any gas station. You can get it anywhere you go. So that's not a problem. Finding it isn't a problem. The question is it very helpful? And there have been a number of studies in the last 5 years on it. The most recent meta-analysis published earlier this year really showed no significant effect on muscle pain or effect on plasma CK levels. Some of the problems with the coenzyme Q10 studies is they're probably not designed the way we would like to design a study, which would be prevention. These are all treatment. When somebody has myalgias, if you give them coenzyme Q10, can you keep them on the statin? We don't know the answer about pre-treating people with coenzyme Q10 in a large trial, if that's effective. I think the vitamin D thing is pretty interesting. A couple of studies from earlier this year, a meta-analysis of 7 studies with lower vitamin D levels. A more interesting study to me is this study of 146 patients who came from a lipid clinic where they got the referrals for everybody who couldn't stay on a statin. So they got all those people that we've tried and tried and tried, and the person says, no, 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 I'm not going to take a statin. And then our last ditch is, let's send you to a place where they can keep people on statins. They got some tricks up their sleeves we don't know. And what they did is they looked at people, looked at their vitamin D levels, and they decided anybody with a vitamin D level, really 30 or below, they would put on megadose vitamin D and see how they did with their statins. So they put these people on 50,000 to 100,000 per week of vitamin D if their level was on the low side, and they were generous. They called 30, 32 low, and they got their levels on average up to 55, and they were able to keep 95% of their previously statin-intolerant patients on a statin. So pretty promising. Now, most of our patients don't end up being vitamin D deficient who have statin myalgias, but for the subgroup that are, this may be a very, very reasonable trick to try to see about keeping people on statins. And the important thing is these people could keep them on them for a long time. A couple of years they followed these folks out. Okay, same guy. I said, okay, well, why don't we try some vitamin D? And he says, I don't want any of that natural crap, which is really hard to believe that I found a guy like that in Seattle. But wants to know what medication you would prescribe next. So he's saying, I'm not going to take this, I don't want to do the vitamin D thing, but I want to know which drug you want to give me. We restart his pravastatin, take him with naproxen daily, start him on 10 of rosuvastatin twice a week, or start him on simvastatin 5 days a week. Okay, 55% of you want to do the potent statin a couple of times a week, picking rosuvastatin. I think that's a great answer here in this patient who has had so much trouble with statin-related myalgias. Many things have already been tried and they haven't been successful. I think there's certainly some limited evidence for this, and let's go through that. One of the frustrating things when you look at how do we manage people with statin myalgias is, for as common a problem as it is, there aren't big studies. We would hope there'd be 300, 400, 500 person studies because it's so common, but no, we're left with studies of 40 to 80 patients. This is a retrospective chart review of previously statin-intolerant patients in a lipid-lowering clinic. 40 patients received 5 milligrams of rosuvastatin twice a week, or 30 of them got that, and 10 of them got 10 milligrams twice a week. They all had LDL reduction, 54% reaching NCEP goal. only 8 patients couldn't tolerate this. So they got 80% of their people back on statins who had been recurrent patients who had problems with statins. So that's pretty good because you look at the population they're looking at are people that nothing works. So 80% in that population is pretty good. Another small study gave almost the same statistics. This is a retrospective study of patients who were statin intolerant, then given every other day rosuvastatin. Average dose was 5.6 milligrams every other day. 72.5% of the patients tolerated rosuvastatin, with half of the patients meeting their LDL target goal. I think the thing that makes us nervous about this is we're giving them every other day rosuvastatin, and we certainly know that there's a lot more to cardioprotection than meeting a LDL goal. So the fact that they're not on the drug full-time, we don't have outcome studies on this. But at this point, our goal is get people on statins if we can by any means possible. So what is a good approach to patients who have myalgias on statins? I think the first thing we want to do is check a CK, check a TSH. Patients who are hypothyroid are more likely to have statin-related myalgia, so that may be something easily fixable. Vitamin D level we talked about. Stop the statins. Make sure that this is actually statin-related myalgias. There are some interesting smaller studies that showed a lot of patients who think they have statin-related myalgias, they don't get better when you stop the statin, so it may be something else. Then you can restart the statin at a lower dose, or you could choose to change a statin. If that doesn't work, you can pick some statins that seem to be a little easier. Fluvastatin at 80 milligrams. Problem with fluvastatin, it's about as effective as giving them jelly beans, but it seems to be better for the myalgias. Every other day, rosuvastatin, or twice weekly at a higher dose for rosuvastatin. And then if you absolutely can't get them on a statin, then you can consider ezetimibe. So why do I think this is such an important side effect? This is something that we see every single day in our clinics. We're always having somebody coming back with this, and having a strategy that helps us keep patients that need to be on statins is really helpful. A 60-year-old man develops pain in his feet over the last week. He describes the pain as burning and sharp, no swelling or redness. He has a history of alcoholism. He quit 3 years ago. Hypertension, coronary disease, prostatitis, and diabetes. He's taking rosuvastatin, lisinopril, metformin, levofloxacin, and amlodipine. Hyperesthesia on both feet on exam. What do you recommend for him? So this guy has had a fairly sudden onset of burning and sharp pain in his feet. You see his past history. He's on rosuvastatin, lisinopril, metformin, levofloxacin, and amlodipine. Hyperesthesia on both feet. What should we do? Start B12 supplementation, stop the rosuvastatin, stop the metformin, stop the levofloxacin, or stop the amlodipine. So 44% of you want to stop the levofloxacin. People want to stop the amlodipine. I agree. I think that at this point, I'd be worried about a neuropathy related to the quinolone. The reason, it may be that his problems are not related to it, but it's a bad problem, and we want to stop the drug as quick as we can if that occurs. This complication has been known since the 1990s, so this is not a new side effect. It can occur early on. Most of them are in the first week of the medication. The most common initial symptom are paresthesias, as this patient had. And we got a letter from the FDA in August 2013 reminding us of this because of more people that were having this, and this hadn't been picked up. So I think that's a reason to be aware of this. I wanted to take this opportunity to cover some of the more common quinolone-related side effects, since these, again, are things that aren't that uncommon to see. Reports of shoulder, hand, and especially Achilles tendon rupture, and much more commonly tendinitis related with quinolones. As far as tears, the Achilles is the most common site. They can occur at any time during the course of treatment. There are some risk factors that make this much more common. If somebody is older, if they are thinner, and if they are also taking corticosteroids, all of these increase the risk of Achilles tendinitis and tendon rupture. So just to kind of catalog some of the quinolone side effects, tendon rupture, and somebody might say, well, how common is that? It's not that uncommon. I've been in practice for 25 years. I don't put a ton of people on quinolones. I put them on when they need them, but I've seen 6 of these, and more worrisome to me is I've gotten 2 calls from attorneys who wanted to try to find an expert witness for Achilles tendon rupture cases, and that kind of freaked me out. I go, well, why are you suing a doctor for a known side effect? And they go, oh, well, they didn't counsel them that this might happen. So that kind of worries me, so I want to make sure you guys all heard about this. Insomnia, confusion can certainly happen with the quinolones, and we try to time the dosing so we're not giving it to them at night to make that worse. We talked about peripheral neuropathy. There's a slightly increased risk of arrhythmia, and some quinolones more likely than others. And there's some noise about retinal detachment. There are split studies on this, but another thing that we should keep our eye on. So why is this important? Well, whenever we get those FDA letters, things become black box warning type things. We are expected to know this and know this really well, and certainly the lawyers remind me of that. A 72-year-old man is brought to the ED with altered mental status. He's been confused for 2 hours. He has a history of hypertension, depression, GERD, and a herniated cervical disc. His wife has diabetes and is treated with metformin. Your patient is taking amlodipine, bupropion, lansoprazole, tramadol, sertraline, and aspirin. He's oriented only to his name. His neurologic exam is non-focal. He gets some labs, and his sodium's a little low at 131. His BUN's 20. His creatinine's 1.5. His glucose is 40. UA is normal. So we're feeling like, okay, we have some information here that will help us understand why he's got altered mental status. So my question for you is, we know that he has got a low glucose. Remember, he's taken amlodipine, bupropion, lansoprazole, tramadol, and sertraline and aspirin. What do you think the most likely cause for his altered mental status is? Is it his sertraline, bupropion? Is it a problem with the tramadol? Is he taking his wife's metformin? Or is it due to lansoprazole? Okay, so 24% of you like tramadol, 39% think he's checking out some of his wife's meds. So the point of this case is C, to discuss some of the more recent information on hypoglycemia associated with tramadol use. Certainly, it's very unlikely for him to get hypoglycemic with metformin. It's not absolutely impossible, but it's very, very unlikely. So I think those are both good things to be thinking about. And that wouldn't be the first time somebody took somebody else's meds that I'd ever seen. So here's a study that was published back in December in JAMA. It was a nested case control study. And the reason this study was done is that there have been case reports over the last decade of hypoglycemia with tramadol use. And the researchers wanted to see, well, how likely is this? Is this really a true association? So that's the reason. They didn't just randomly decide on this. They actually were basing it on a series of case reports that had sort of brought this to light. So nested case control study of 28,000 adults newly treated with tramadol, 305,000 adults newly treated with codeine for non-cancer pain between 1998 and 2012. Cases of hospitalization for hypoglycemia were matched with up to 10 controls. And compared to codeine, tramadol use was associated with an increased risk of hospitalization for hypoglycemia with an odds ratio of 1.52 with good confidence intervals. More interesting was that the first 30 days of use were the highest risk. So there are individuals that seem to be at high risk. The vast majority of the population it's not a problem with. So it's a early onset type of side effect if it's going to happen. This was just published a couple of months ago. It was a study on hyponatremia associated with tramadol, population-based cohort of 332,000 patients. Again, tramadol, codeine. It's really sub-looking at this other series of patients we talked about, a very big database. And they found that these patients had a much higher rate of being hospitalized for hyponatremia, 4.6 per 10,000 compared to 1.9. So almost double the risk compared to codeine users. So these are infrequent problems with tramadol, with hyponatremia and hypoglycemia, but just things that I want you to have heard about and thought about. Tramadol has other things about it. Seizures are probably the most known side effect of tramadol. This becomes a bigger problem the older our patients get. Serotonin syndrome, tramadol, if it's mixed with higher dose SSRIs and a couple of other drugs that can raise serotonin levels, could be a problem. So tramadol had kind of gotten a little bit of play as well. This is a safer way to go than narcotics for our patients. Just think it's important we know the whole risk package we get. We tend to understand the risk package we get with narcotics. With tramadol, there may be some of these other side effects we may not be aware of. An 83-year-old with type 2 diabetes is brought in for evaluation for altered mental status. She's been feeling really not very good for a couple of weeks and has been undergoing treatment for presumed H. pylori gastritis and a UTI. Her meds are bismuth, glyburide, sitagliptin, omeprazole, amoxicillin, trimethoprim sulfa, and lisinopril. Her sodium is 132, potassium is 5, chloride is 100, glucose is 30. What do you think the most likely cause of her hypoglycemia is? Is it an amoxicillin glyburide interaction, amoxicillin sitagliptin interaction, omeprazole glyburide interaction, trimethoprim sulfa glyburide interaction, or a bismuth glyburide interaction? Okay, so 36% of you chose trimethoprim sulfa glyburide. Some liked omeprazole glyburide. So this is what I'm going to cover now is a fairly newly described trimethoprim sulfa glyburide interaction, which shouldn't be a surprise because of the way that the way trimethoprim sulfa is metabolized. And there certainly were case reports before this study came out. And again, that's always the first thing we see is some case reports, and then we have people look at it, and it gives us a little better idea of how likely something is. One of the problems with drug interactions is we don't have nice prospective studies. I'll show you a couple where they looked at effect of drugs on people, but when they do prospective studies, they take healthy folks. They never study the people that these problems occur in. So in this study, it was to look at what the prevalence of co-administration trimethoprim sulfa and sulfonylureas was, and what was the risk of emergency room visits for hypoglycemia. So these were people with severe hypoglycemia enough to bring them into the ED. 34,000 Medicare beneficiaries taking glyburide or glipizide in 2008 were the study population. The odds ratio for hypoglycemia was 3.89 with good confidence intervals for glipizide. Odds ratio 1.8, 7.9 for glyburide. In the patients who got trimethoprim sulfa, comparing them to patients with amoxicillin. So it looked like trimethoprim sulfa was more likely to do this than amoxicillin, which was their control antibiotic. Why are these important interactions? These are rare, okay? So these are not things that are common, just not something that we see very often. But again, it's one of those things as we make decisions on best versus an alternative, if we know a certain drug has 4 or 5 things we have to worry about and there's an alternative that's just as good, we may choose that alternative. Tramadol use is not decreasing. It may be increasing because of tighter narcotic prescribing laws. And hypoglycemia as a direct or drug interaction side effects occurs more common in our elderly patients and especially in our patients who are on more and more medications. Okay, a 74-year-old is brought to the office by concerned family members. Recently, he's spent all day at the casino nearby and has lost much of his retirement savings on gambling. The patient reports this is a newfound passion of his. Past medical history, coronary disease, depression, Parkinson's disease, GERD. Meds are fluoxetine, rabeprazole, levodopa, carbidopa, pramipexole, metoprolol. What is the most likely cause of his newfound uncontrollable gambling? Is it fluoxetine, rabeprazole, levodopa, carbidopa, pramipexole, or metoprolol? Okay, so 30 of you like fluoxetine, 43% of you levodopa, carbidopa, and 25% pramipexole. So from this list of suspects, I probably would pick the pramipexole. Levodopa, carbidopa, possible, less likely with the fluoxetine. And we'll talk a little bit about what's out there on literature about medication-triggered compulsive gambling. This all started back about 12 years ago when there was a series of 9 cases reported in neurology in this one individual's practice with a rate of 1.5%. And this was somebody who was using pramipexole at higher doses, a neurologist using this for the treatment of Parkinson's disease, not using tiny doses for restless leg syndrome. So again, higher doses is where the original original information came from. Another study came out just a couple of years later, another 11 patients over 3 years who developed compulsive gambling with dopaminergic drugs. 9 of 11 had received pramipexole, 2 ropinirole. Also, these patients had been on levodopa, but the problem occurred once they started on these other drugs. 8 of 11 got better within days to months of stopping dopamine agonist therapy. 3 of 11 just thought it was so fun it didn't matter when they stopped the drugs. And interestingly, other compulsive behaviors began developing in some of these patients, overeating, spending, and hypersexuality. So this is a study that was published just a few years ago that kind of looked at, okay, are these impulse control disorders more common in Parkinson's disease in general, or are drugs part of this? 3,090 patients treated with Parkinson's disease receiving care at 46 centers in the U.S. and Canada. An impulse control disorder was identified in 13.6% of patients, gambling at 5%, compulsive sexual behavior in 3.5%, compulsive buying in 5.7%, binge eating in 4.3%. 3.9 had more than one of these. They were more common in patients who got dopaminergic agonists than in patients not taking a dopaminergic agonist, 17 versus 6, almost 7%, with an odds ratio of 2.72. So it appears that, yes, impulse control disorders may be certainly prevalent in patients with Parkinson's disease, but the drug therapy brings these out a little bit more. So why is this one important? Well, this is old news, and I didn't want to just put in old news, but what is new is that physicians and pharmaceutical companies are now starting to get sued over compulsive gambling, which is just a bizarre thought. But there's a lawsuit actually against a physician that's ongoing right now, and there are a couple that have been against drug manufacturers about this. And these guys all advertise it on their websites, so just be aware of this. The one disclaimer is, I mentioned we most commonly probably, as general internists and specialists who see patients with a simple symptom, we usually prescribe pramipexole for restless legs at very, very tiny doses, and this seems to be a dose-response type problem. 66-year-old woman comes in with fatigue. She has a history of bipolar disorder and reflux disease. She's felt well the last few months until the last few weeks, so just recently she's felt a little bit more tired. She's on rabeprazole, lithium, paroxetine, calcium. Her physical exam is normal. As part of her workup, she gets some labs, and surprisingly, she's got a sodium of 120. The rest of her labs are not too exciting. Why do you think she has a low sodium? Is it hyperlipidemia? Is it the lithium she's on, acute psychosis, rabeprazole, or paroxetine? So there's something in the brainstem about lithium and sodium. Now, so we'll all be in nursing homes and we'll still remember there's something about lithium and sodium and we won't be able to control anything else. But the right answer here is E, paroxetine. And remember, lithium is more likely to cause nephrogenic DI, more likely to make the sodium go up. And paroxetine is an important cause. All the SSRIs are an important cause of hyponatremia. Again, percent-wise per drug is small, but so many people are on it. It's one of the more common reasons for hyponatremia and people who end up in the hospital with hyponatremia from a drug cause. Once you get rid of the diuretics, the SSRIs are probably the second most common drug to do it. And this is important. There is a subgroup of people that are even at higher risk than the average person to get hyponatremia with an SSRI. They're little old ladies, and they're thin little old ladies. They're generally over the age of 65. If they're on a diuretic, it's much higher risk and low body weight. And I once proved this to myself. I put a 93-year-old patient of mine who'd been on hydrochlorothiazide for 25 years, never had any problem with hyponatremia, on citalopram for depression. And her family brought her in 4 days later when she wasn't talking anymore, and they said, she's depressed, she's ready to go. And my first thought when somebody looks really sick after I've seen them is, what have I done to them? And so I got labs, and I'd gotten her sodium down to 108 by adding citalopram on top of her already well-tolerated hydrochlorothiazide. So this is definitely real. She fit every criteria. She She had a BMI of about 19. She was 93. She was on a diuretic. So this definitely occurs. So just a quick comment on drug-induced hyponatremia. Hydrochlorothiazide, most common, about 30 to 40% of patients will have at least a mild hyponatremia when they're on it. Most patients don't. You don't have to stop it because of it, but we notice it. SSRIs, SNRIs both cause this. NSAIDs. For many years, we've known the effect of carbamazepine, and then in the young person who comes in with an unexplained severe hyponatremia, think about ecstasy use. There have been many case reports in the last 5 years of patients coming in with seizures and bad hyponatremia related to hyponatremia occurring with ecstasy use. So why is this one important? Well, this is a potentially severe and somewhat predictable problem that we can look for in our at-risk population. And that at-risk population doesn't mean we won't use SSRIs in them, but we'll probably monitor them. That's a group you may want to check a sodium. If you put a little old lady on an SSRI, you might want to check one sooner than later. 72-year-old man, status post-aortic valve replacement 2 years ago for aortic stenosis, presents with widespread bruising on his back and legs and some bruising on the back of both his hands. His last INR was 3 weeks ago and was 3. He states he saw an MD 6 days ago and was put on for a cough and was put on a white tablet. When asked to clarify that, he said it was a large white tablet. His chronic medications include warfarin, albuterol, and nortriptyline. So we got a guy who's done well with his aortic valve replacement, keeping his INR at target between 2.5 and 3.5. He was at 3. Now he's bruising, and as you do some detective work, you find out somebody put him on a large white tablet 6 days ago for a cough. You see he's on just warfarin, albuterol, and nortriptyline. What medication was he put on? Was he put on amoxicillin, codeine, cefixime, azithromycin, or trimethoprim sulfa? So which of these do you think he was placed on? Okay, so 34% of you like trimethoprim sulfa. I think that's what I'd pick, both the size of the tablet and the biggest interaction with warfarin. And we'll talk about sort of quantity of interaction and also quality of interaction. Azithromycin certainly has an impact on INRs. That's absolutely correct, and it's certainly possible. I used to say, well, that tablet isn't white, but I'm wrong. I was lecturing somewhere, and somebody sent me a picture of a generic azithromycin that was white. So I think both of those are good answers, but trimethoprim sulfa we got to know because we're using so much of it now because we use it for community-acquired MRSA so often, seeing more and more people running into trouble because we got so much of a population on warfarin as well. So what are the drugs that decrease metabolism, increase INRs in patients on warfarin? The most severe are trimethoprim sulfa, erythromycin. Both of those, they get to steady state level relatively quickly, so in a couple of days you start to see a really major impact. Drugs like amiodarone that have half-lives like 3 or 4 decades or something like that, it takes a while for that to happen. So we see the jump in INR much quicker with these shorter half-life drugs. The azole antifungals cause a problem, and then metronidazole. Then we got a group that really makes us squeamish because it's not predictable. The ones on the left we kind of avoid, or we know that we're going to get into trouble, but quinolones can certainly bump the INR, but don't always do it. Clarithromycin, azithromycin definitely do it. Even omeprazole. Omeprazole has an effect on the P450 system. It affects the metabolism of warfarin. Doesn't raise the INR like some of the other drugs, but it may potentiate a second interaction that may occur. I love this study not because it's a huge study, but it gives me some numbers to kind of run in my head on the average bump in INR with different antibiotics. This is a retrospective cohort study, 104 patients on stable warfarin therapy. They looked at effective INR of terazosin, which was their control. Terazosin not known to change INR. Azithromycin, 32 patients. Levo, 27. And trimethoprim sulfa, 16. Mean change in INR was minus 0.15 for terazosin, plus 0.51 for azithro, plus 0.85 for levo, and plus 1.76 for trimethoprim sulfa, with 2/3 of the patients on trimethoprim sulfa going out of their target range. 76-year-old man is admitted with increasing shortness of breath. He has a long history of COPD and has had a recent productive cough. He is admitted to the hospital and treated with amoxicillin, prednisone, codeine, and albuterol. Past medical history, atrial fibrillation, hypertension, COPD, and GERD. His outpatient meds are metoprolol, warfarin, pantoprazole, lisinopril. His recent INR 2 weeks ago was 2.2. On hospital day 6, it is 4.3. What is the most likely interaction? So we got a guy with COPD brought into the hospital, and he's getting amoxicillin, prednisone, and codeine, albuterol, and his INR has gone up from 2.2 to 4.3 during his week in the hospital. What do we think is the cause? Prednisone, amoxicillin, codeine, or amoxicillin and pantoprazole? Okay, so 72% of you chose a drug interaction, and this is actually due to prednisone. So 23% of you got this one. And this is not a big interaction. It's a small interaction, but it's one that happens a lot. And I find it really helpful for me to know if I see a patient whose INR has gone up, and then I look at it and see he was just put on prednisone, most of them are coming off their prednisone. I know not to overreact to it. I know that within the next week they're going to be off the prednisone, and their INR is probably going to go back to their baseline. The problem is when we overreact to this and then we decrease their warfarin dose, then we take the prednisone away, and then the next INR is undershooting. So it's not that this usually raises the INRs too high. It's that we just need to know it's out there raising INRs in our patients. This data comes from a study done in an anticoagulation clinic in patients. They looked at patients getting steroids. They excluded everybody in their database who were getting steroids, but also were on anything that had any kind of reports for raising the INR. They found a bump between the pre-steroid and the INR on steroids of 1.24. 62% of people overshot their targeted range. So this is definitely something that's out there and something that we'll see, and we just don't want to overreact to it. Now, if somebody's going to be on steroids on a stable dose for a long time, we'll have to adjust things. So what are the important warfarin interactions? Trimethoprim sulfa, probably the most common big warfarin interaction out there that people will see. Acetaminophen can raise the INRs if you give it to people on a daily basis. If it's used once in a while, it's not a problem. But if people take it on a daily basis, you can bump the INR. We talked about prednisone because it's not often suspected. Simvastatin has a very mild effect on INR, and it can be part of a series of drugs together that can cause a problem. And then omeprazole can potentiate other drug interactions with warfarin. A real quick comment on 10A inhibitors, since more and more people are on them, and the question comes up all the time is, do they have less drug interactions? And the answer in general is yes. The drug interactions that increase the risk of bleeding or cause increased problems with bleeding, ketoconazole, itraconazole, clarithromycin, and ritonavir, these are some of the same ones we've talked about several times, the azole antifungals, especially clarithromycin, very active drugs on affecting metabolism. Decreased efficacy, pretty much anti-seizure drugs, and my least favorite natural product of all time, St. John's wort. St. John's wort has remarkable drug interactions and really affects metabolism, a number of drugs, and will cause increased metabolism and failure. There have been case reports of transplant failure because of cyclosporin metabolism. There have been case reports of antiretroviral failure because of effects on efavirenz. And there have been reports of pregnancy because of effects on oral contraceptive pills in patients taking St. John's wort. So of the natural products, that's probably the one that worries me the most. Why are these important? Well, warfarin still, in a 2011 study, was the most common cause for drug interactions causing hospitalizations. Okay, we're in the home stretch here. 70-year-old man presents with nausea and weakness. He has a history of coronary disease, hypertension, and depression. He was seen a week ago for nausea and abdominal pain and was started on treatment for ulcer disease with H. pylori. For H. pylori, his meds are aspirin, nifedipine, omeprazole, amoxicillin, fluoxetine, and clarithromycin. His blood pressure is 90/60. His pulse is 100. His BUN is 35. His creatinine is 3.8. Potassium is 4.8. So we have a guy coming in weak and sick. He has a history of coronary disease, and he was just started on treatment for H. pylori in the last week. What do you think the cause of his renal insufficiency is? Allergic interstitial nephritis, a pravastatin-clarithromycin interaction, a pravastatin-nifedipine interaction, or a nifedipine-clarithromycin interaction? Okay, good. So this is that one I touched on earlier, clarithromycin having an impact on calcium channel blockers. And in our very first case, we had a potential for that interaction if that patient had been put on clarithromycin. And this clarithromycin can definitely increase the levels of nifedipine, decrease the metabolism of vasodilating calcium channel blockers, and has been associated with a couple of things: profound hypotension requiring ICU admission and acute renal insufficiency. This is a retrospective study from Ontario over about a 10-year period of older patients with a mean age of 76 who were newly co-prescribed clarithromycin or azithromycin while taking a calcium channel blocker. Co-prescribing clarithromycin versus azithro with a calcium channel blocker was associated with a higher risk of hospitalization for acute kidney injury with an odds ratio of 1.98. The risk was highest in the dihydropyridines. They had some risk with verapamil and diltiazem, but much higher with dihydropyridines, the amlodipines, nifedipines, felodipines of the world. So I mentioned clarithromycin a few times, and it still is being used quite a bit, and there are very few clinical benefits of clarithromycin over azithromycin. There are some where it's a little bit better drug, but I think we have to be sure that's why we're using it, because it clearly has more drug interactions and more potent drug interactions than alternatives. Major drug interactions with the statins, major interactions with calcium channel blockers, can increase levels of glipizide and glyburide causing hypoglycemia. Huge drug interaction with colchicine, and many deaths have been reported, and that was part of the information that was submitted to the FDA that led to the removal of the generic colchicine off the market and giving us wonderful $200 a month Colchris. 82 major drug interactions are reported, and so as far as safety, azithromycin is a safer macrolide as far as drug interactions. It has its drug interactions you need to know, but not as severe as clarithromycin. Why is this one important? Well, clarithromycin continues to be used despite its multiple drug interactions. 85-year-old man brought to the ED for evaluation of weakness and nausea. He was diagnosed 10 days ago with prostatitis. His other problems include hypertension, heart failure, and renal insufficiency. He's on carvedilol, furosemide, trimethoprim sulfa, verapamil, and digoxin. Blood pressure 100/60, pulse 100, temperature 36.9. He's got a murmur, lower extremity edema, and on his labs we see his potassium is 6.8, so that sounds the alarms. His BUN is 37, his creatinine is 2.3. What is the most likely cause of his hyperkalemia? Is it his chronic kidney disease, carvedilol, trimethoprim sulfa, verapamil, or digoxin? Okay, so two good answers here. Trimethoprim sulfa, 54% of you chose, and I think that's probably the right answer here. Digoxin in high doses can certainly lead to some hyperkalemia and problems, but we could say his creatinine at 2.3, and maybe he's on too high a dose of digoxin. But of these, trimethoprim sulfa is a real setup in a patient with chronic kidney disease and with low GFR, such as this gentleman would have. This is a study that was done on older men who were otherwise doing well. And this is one of the few prospective studies where they actually looked at what the effect of drugs are in an at-risk population. 33 patients received standard dose trimethoprim sulfa for 3 or more days comprised the study group. 20 patients who received oral cephrodine or amoxicillin for 3 or more days comprised the control group. Patients taking ACEs, NSAIDs, beta blockers, or had any kidney disease were excluded. So they were careful and tried to take the lowest risk of the group. Serum potassium concentrations in the patients receiving trimethoprim sulfa increased by 0.31 at the end of therapy compared to the other antibiotics that they looked at. So very, very good p-value. These people didn't get into trouble with it, but again, they selected the healthiest of the group, the people who didn't have chronic kidney disease. So again, it shows us that trimethoprim sulfa does have an interaction and an effect. And this was a study published last year, sort of touched on this as well. It was a study on trimethoprim sulfa use and sudden death to determine whether prescription of trimethoprim sulfa with an angiotensin-converting enzyme inhibitor, or an ARB, is associated with sudden death. They looked at almost 40,000 sudden deaths. 1,000 occurred within 7 days of exposure to an antibiotic, and were matched with almost 4,000 controls. Relative to amoxicillin, trimethoprim sulfa was associated with an increased risk of sudden death with an odds ratio of 1.38. The reason that patients on trimethoprim sulfa get hyperkalemic is an effect from trimethoprim. The mechanism is that trimethoprim acts very much like amiloride, a potassium-sparing diuretic, and reduces urinary potassium excretion. And those patients who have lower GFRs are more dependent on this and can get higher potassium levels. It is much worse when it's added to an ACE or ARB, but we have many, many, many of our older folks who are on ACEs or ARBs because of heart failure and hypertension and heart disease. The drugs that have been, the antibiotics that have been linked to sudden death, trimethoprim sulfa, probably due to a hyperkalemic mechanism. Quinolones probably due to QT prolongation. Azithromycin probably due to QT prolongation. Why is this side effect important? Well, sudden death always gets people's attention, and we're having more and more of our patients who are chronically on drugs that are very, very helpful for them, but that put them at risk, the ACE inhibitors, the ARBs, and spironolactone. This is our last case here. A 62-year-old man with a history of an MI 4 years ago presents with right hip pain. He has had discomfort with walking for the past 6 months. An X-ray reveals moderate osteoarthritis. The most recent labs, BUN6, creatinine 0.8, glucose 100. What will be the most appropriate management plans? We have a guy who had an MI 4 years ago, has right hip pain. X-ray reveals osteoarthritis. His labs look okay. What would you recommend? Acetaminophen, oxycodone, ibuprofen, diclofenac, or celecoxib? Okay, so 69% chose acetaminophen, 3% oxycodone, and a few chose NSAIDs or COX-2. I think A or B would be reasonable things here, and I would probably steer away from the NSAID or the COX-2 because of his MI history. And we're going to go through some of the data there and the new FDA warning. So this is a study that looks at the risk of MI in patients who are NSAID users. This is a large cohort study from Denmark, almost 100,000 patients with a mean age of 69. They looked at pharmacy records and medical records for all patients over 30 with a first-time admission for MI between 1997 and 2009, and then they tracked NSAID use. Hazard ratio for death with NSAID use was 1.59 at 1 year, 1.63 at 5 years. Risk for recurrent MI was 1.3 at 1 year, 1.41 at 5 years. And another study showed even short-term treatment with NSAIDs was associated with increased risk of death and recurrent MI in patients who had had a prior MI. This is probably the largest meta-analysis looking at NSAIDs and COX-IBs and looking at the overall risks with these. They looked at major vascular events, coronary events, stroke, hospitalization for heart failure, and then also upper GI complications, which we are well known to be associated with these classes of drugs. 639 randomized controlled trials with over 225,000 participants. COX-IBs and diclofenac associated with an increased relative risk of major vascular events, ibuprofen increased risk of MI, all NSAIDs and COX-IBs increased risk of heart failure hospitalizations, and all increased GI bleeding risk. The highest with naproxen, the lowest with COX-IBs. This was actually, I'll talk about it in a minute, but this data was used by the FDA for their most recent warning that they gave us in July. And then this last study just looks at the impact of NSAID use on hospitalizations and diagnosis of heart failure in older patients. 365 cases of patients admitted with heart failure compared to control patients. NSAID users had an odds ratio of 2.1 for admission for heart failure. The odds ratio jumped to 10.5 for first admit for heart failure if the patient had heart disease and used NSAIDs. And the risk for admission for heart failure correlated with pretty much the half-life of the drug. The longer-acting NSAIDs were a bigger problem. So patients that were on NSAIDs that worked for longer periods of time probably had more problems with renal salt and water excretion and were more likely to get admitted for heart failure. Why is this important? Well, in July, the FDA strengthened the NSAID cardiovascular risk warning, citing that meta-analysis and really saying that in patients with known heart disease, people with MIs, that NSAIDs are certainly a higher risk drug and that we should all know that. What do I want you to remember from this talk? Watch carefully for interactions with trimethoprim sulfate, tramadol, erythromycin. Think twice before prescribing quinolones. Statin myalgias are common, and come up with a strategy on how to manage them. And of the statins, pravastatin probably has the least drug interactions. I appreciate your attention.